there, and welcome to Let's Talk About Health. I'm Dr. Madeline Mant, and today we're speaking to Ali Sawyer, who's going to tell us all about the life of a physiotherapist. So welcome, Ali. Thank you so much for being here.
Hi, thank you for having me.
So Ali, let's get right into it. What is your job? What is a physiotherapist?
So I think when most people think about physiotherapists, they probably think about sports physio. I get asked if I do massage most of the time. So I can categorically say, no, that's not only what a physiotherapist does. It was perhaps the way that I thought about it prior to going to university. And actually, if you can think about any aspect of a hospital or any aspect within health, there's probably a physio team there. So a good example, there are physios that do deal with neurology. So if someone's had a stroke, has got Parkinson's, they'll have a physio as part of their team to help rehabilitate them. Of course, there is MSK physio, which is part of my job. I would say, broadly speaking, if we were talking about physio as a profession, it's about looking after a person holistically and helping to rehabilitate them to live their best life. So that would be it in a nutshell, I would say.
Right. No, that's super fascinating. And so how does one become a physiotherapist? What was your journey to this, and kind of what sort of skills did you gather along the way?
So coming into physio, I decided quite young that I wanted to be a physio, and the reason it was because I told my parents, probably when I was a touch younger, that I wanted to be the first female England football manager, as one does. And my parents, as supportive as they were, thought that was possibly not the career that I was going to go down. And I was very, very much into sport. So I played football. I played a lot of sport at school as well. And so rehabilitation side of things seemed much more interesting to me. And again, particularly it was sport that got me into it. I came very, very close to applying to do fine art or history of art instead. And so it was actually a conversation with my dad who said, well, you can do art as a hobby, you can still enjoy doing art, but actually it would be really good to have a career when you come out of university, which actually I thought was really great advice. The slight problem was I graduated in 2008, which is when we had a huge recession in the UK, and there were no physio jobs. So, I was sort of thinking, great, thanks, Dad. I could have been painting pictures for 3 years, but, here we are 12 years later and I'm still a physio. So, that's got to be good.
So in the end, it seems to have worked out okay, which that's the kind of journey we like to hear about. But I've heard you use some of these words already, but I'm really interested to hear a little bit about the language of physio. So we talk in anthropology of health about how we use terms like health and illness and sickness and wellness and disease and that sort of thing. So could you give us a sense of how some of that language is used in physiotherapy?
So in terms of health and illness, so I would say within MSK physio and in pelvic health physio, I don't remember the last time I used the term illness, which, again, that probably says something about the areas of physio that I'm within, because again, if perhaps I was working within a more acute hospital environment, that might be quite different. But again, I think that comes down to how we treat patients, and we're trying to treat them holistically. And so I think that's, for me, that's what health is. And that's how I would describe health to my patients. So yes, we want this to be moving better. We want that to be stronger. As I said, are we getting enough sleep? If we're not getting sleep, our cortisol levels are going to be higher. We know that causes inflammation, and we know that makes or the experience of pain worse. Are we exercising regularly? And again, not exercising necessarily from a weight perspective, but actually a mental health perspective for that endorphin release. Are we exercising to move our body to make it stronger? And getting all of those good health benefits, and then having all of the other things such as weight loss, for example, being a happy side effect of that. And so I think that's where within physio, we've moved along quite a lot in terms of our view on health, and looking much more, as I said before, from a biopsychosocial perspective. So not just honing in and being tunnel visioned on a knee or on a back.
No, I'm really interested in you talking about holism, because that's a big anthropological thing, is pulling the body and thinking about the body as an embodied experience, and it's political and it's social and it's physical, it's all those things. But I like hearing also about physiotherapy, not only as like a reactionary thing of, like you said, I've hurt my knee and now I must focus upon it, but on kind of the whole body look at movement. That's a really powerful message. And so thank you for bringing that to our students and to this today, because I think that's a great example of we can be defensive and offensive with the way in which we are thinking about maybe our movement.
For sure. And I think exactly as you said there, actually, we should be looking at preventative care You know, we shouldn't just be looking at reacting to a situation. So can we, be as healthy as we can be, whatever that may look like for that particular person? So are we moving well? Are we sleeping well, as I've said there? And actually, if we've got those things in place, are we going to potentially prevent certain things from happening? I would probably say so. Examples of the language that we perhaps have changed is looking at things like arthritis and the way that arthritis is described to a patient. So for example, we've always used the term wear and tear, and actually, again, to certain people that can have a really negative connotation that their joint is wearing out. And actually, we know that arthritic changes, they're normal. You know, that is just, it's the normal aging process of the body. And actually, if we, scanned, and something I always say to my patients, if I scanned 100 people of age 55, for example, at least 50% of them would have arthritic changes and not even know about it. And so I think that's where it becomes really important that A, patients knowing what is normal, but B, being really conscious of the types of language that we use around our patients, because what we will often find is if they've got this negative connotation, if they think, for example, my back is wearing out, they become fearful. And it's that fear then that stops them from moving. So of course they become stiffer, they become weaker. So when they try to do something, it hurts. And then it kind of perpetuates that notion they've got that movement is dangerous. We're supposed to move and we need to get moving. And our language can play a really big part in helping disseminate some of those fears that patients have. So for example, something like urinary urge incontinence, certain types of incontinence, overactive bladder, different types of pelvic pain. One of my specialities, for example, is sexual pain, so people who can't have sex because it's painful. And a lot of these issues arise from habits that we've picked up from a young age. And actually my big thing for this next year, hopefully, fingers crossed, to sort of couple of years, is to look at getting better sex education within schools, that is looking around those habits. And actually, can we therefore A, save money for the government, which ultimately that's what they're going to be interested in, but also B, save these people from having some really quite distressing symptoms down the line, that if we put some good preventative care in place, we may not have had an issue with.
No, that's fascinating. And I do think about, when you said we don't talk to people about bowel movements, I'm like, I think maybe during toilet training would have been the last time somebody specifically spoke to me about, how are you doing? How are things feeling? And that's, it's intimate and it feels sort of private and all sort of things. But as you say, if somebody's having painful sex or is having to pee 11 times a day and it's, and they're not sure what's going on, having somebody like you to be able to talk about it in a way that is like, yes, it's intimate and private, but also it's normal. And there's a chance to actually, not normal to have certain pains, but normal to be able to speak about those areas and have it be safe. And I think that the idea of sort of safe places has been a really important topic in these conversations I've been having with other specialists as well, that we have to be able to talk about our bodies, otherwise we'll never be able to move forward. So when you're talking about female pelvic health, how are you starting some of those conversations?
So I think there's definitely been a challenge during COVID, for example, because I'm doing all of my work, or the majority of my work, virtually at the moment. So again, starting those conversations online is perhaps a little trickier. I like to do a lot of my, it's something intimate to talk about. So I like to do a lot of my treatment face to face, because I think you can get a better rapport with the patient, which is a really important part of it. They need to trust you to be talking about something so intimate, because I think, of course, if you're uncomfortable, your patient's going to feel that, they're going to feed off of that. And again, that's where language comes into it as well, and being able to talk about things and name them. And actually, so for some patients, I think putting a name to something is so important, because they feel actually they can take ownership of it, and there is hope for them to sort of move forward, and that something can be done. Particularly within pelvic health, we see a number of patients who have been around the houses, they've been to various different specialties that perhaps not necessarily picked something up, not through any fault of their own, but just because it's not their specialty. And so we often see patients who've been, 2, 3, 4, for someone with endometriosis, for example, 10 years plus, who end up coming to see us. And so I think that building that rapport and being comfortable to talk about things that are delicate, is probably the first thing I would say. I personally will attack things pretty head on, because I think for me in this in pelvic health line of work, that's the only way to do it. And I think you start to learn from your patients what they're comfortable talking about. So for example, you might have someone initially who you gauge isn't really all that comfortable, and so you're going to start peppering things in. You're going to build up to those bigger conversations. For example, within pelvic health, with our pelvic pain patients, we have to talk about things like sexual abuse, because of course that can have a huge influence on it. Now, that might not be something I tackle, as it were, in the first conversation if I can see that they're being a little more reticent. However, if they're feeling a little bit more open and I can hear from their language that they are quite comfortable talking to me, then that might be something that I tackle. Again, I would say it's all very patient dependent, and there isn't a right or a wrong. It's just depending on how they're presenting to you at the time.
Yeah, no, this is fascinating, because as somebody who has never received physiotherapy, in my mind, kind of going into it, there's a feeling of, as we talked about before, reactive medicine or treating something that's sort of gone wrong. So the idea of this really important relationship building is something that I'm learning about right now that's really, really important. And the idea that there's so much trust involved, because it is your body, no matter what part of it we're talking about, but particularly, as you're saying, in the pelvic and genital regions, these are regions that might have shame attached, or somebody could, just the idea of it being too private. So I think that's a really powerful discussion of language is really important for not only the kind of biomedical side of things, but also for us to consider potentially going in as a patient, realizing that there's that trust should be built, that rapport is important.
Absolutely. And I think particularly when it comes to, so for example, within pelvic health, we have to do internal examinations, and that, simply just because it's, we're looking predominantly at the pelvic floor. When we're assessing females, obviously men have a pelvic floor as well, so important still to do your exercises, but when we're doing something like an internal examination, that level of trust that needs to be there for a patient to feel comfortable, particularly if they do have pain around the genital region as well. And that's where I feel that sort of full explanation of what you're doing is so important, because I've had a number of patients that have had poor experiences, for example, with something like a smear test, because they weren't relaxed. They are sometimes rushed in and rushed out a little bit, again, for various reasons. Approaching it with explaining what we're going to do, and more importantly, why we need to do it as well. Because I think if people understand why something is necessary, actually, even though it might not be the most comfortable of experiences, they can get on board with it, and they can see that it's important as part of their return to function, or return to being more comfortable.
Yeah, no, this is all super fascinating. And so if somebody's watching this video and now they're convinced that physiotherapy is for them, what advice would you give somebody who maybe wants to get into this field?
So I think I would definitely say go in with an open mind. I certainly went in thinking sports is where I want to go. And yes, I have worked within sports, and I have worked within musculoskeletal medicine for a very long time. But I think you'll be surprised in perhaps what you enjoy that perhaps you didn't expect. So pelvic health was a big one for me. My first exposure of pelvic health was at university in one of my rotations, and then it was something I always sort of touched base on, and then had the opportunity to sort of specialise in a bit more later on down the line, which was great. I think try and get as much experience as you can. So even if that is going and volunteering at a hospital, so you can do, for example, in the UK, you can become a healthcare assistant, and a lot of physios, personally I actually didn't go down that route, but a lot of physios will do some work in a hospital as an HCA initially, and even sometimes whilst they're doing their degree as well. So actually just learning the way that a hospital works, or the way an outpatient department works, is really helpful, because whilst at university they can teach you an awful lot, they can teach you the bare bones, right, intended, of all of the the anatomy, they can teach you the neurology, but actually until you start seeing people, that's when you learn. That's when you're getting your patient mileage. That's when you start to recognize patterns of, okay, so this person responded in this way, so maybe I will try that again another time because it's worked. Experience if you're fortunate enough to be able to do so. My third thing, and this is something that I feel really strongly about, is when you do graduate, is going into an environment where you are going to be well supported. So I went straight into private practice. simply because of my situation at the time and the recession, and there just weren't any NHS jobs. They'd put a freeze on them. What that then meant is I wasn't hugely well supported in the environment I was in at the time. Now, I can only, of course, speak to the practice I was working in at the time, and not for every single one, but I certainly know a couple of my colleagues now who were in a similar environment and have reported the same thing. So I would say when you graduate, if you can go into your local hospitals in the UK, we have a rotation scheme. Again, I suspect it's probably not dissimilar in other countries. The learning and the support you get there is invaluable. You know, I think that's a good route to go. And then if you choose to perhaps decide to go down a different route later on, fantastic, not a problem at all. But you've got that grounding. You know how to deal with those patients. You're seeing those different types of patients come through your door.
No, that's really powerful. I think it's so important too to emphasize the idea that it always takes two with a patient and practitioner relationship. And if the practitioner isn't supported or isn't well in terms of wellness and health, that's also really important. And it could have a negative effect on that relationship. So I'm glad you brought that up. I think that's really important to think about. What does support mean? What do you need as a practitioner? How can you move through your career in a way that feels supportive and also feels like it's healing for you?
I would be remiss if I didn't recognise that it has been much tougher, because we're all in a situation we've never been in before. But it has been so much more important to be looking after ourselves.
And I like hearing the idea that everybody has to be supportive of everybody to ensure that the system can continue to be supportive in a way that is meaningful.
Absolutely.
Thank you so much, Ali, for helping us understand physiotherapy a little better. I know I've learned a whole lot, and I'm sure the audience has too. So thank you.
Good, I'm glad.
Here, and thank you so much to the audience for tuning in. And we will see you all next time on Let's Talk About Health.